In this podcast, we're going to talk about blood vessels, the arteries, and the veins. And your learning objectives, you should be able to recognize sections of blood vessels on glass slides and on histologic images. You should also be able to distinguish between arteries and veins. And we hope that you'll be able to correlate the structure of arteries and veins with the hemodynamics of blood flow that you're going to learn about in your physiology course. So I'm not going to go over this slide again. We talked about it when we talked about the heart. So we're going to talk about the blood vessels here being the arteries, arterioles, veins, venules. We'll have another podcast that will talk about capillaries. We suggested earlier that the walls of blood vessels are composed of three layers. There's a tunica intima, which is the innermost layer, a tunica media, the middle layer, and a tunica adventitia, the outermost layer. The tunica intima consists of endothelium, which is a single layer of cells, a basal lamina with the endothelial cells. There's a subendothelial loose connective tissue with fibroblasts and a few smooth muscle cells, collagen 1 fibers, proteoglycans, and glycoproteins, and there's an internal elastic lamina. And so the tunica intima on the diagram would be shown like this. There's the tunica media, which would on the diagram shown like this, and it would be in both arteries and veins, of course. Tunica media consists of circumferential layers of smooth muscle, reticular fibers, elastic fibers, and proteoglycans. There are prominent elastic lamina in the large arteries that alternate with layers of smooth muscle. We'll show you that histologically in just a minute or two. And there's an external elastic lamina. All the extracellular components of the tunica media are synthesized by smooth muscle cells. You should recall that smooth muscle cells are synthetically very active cells. And then the tunica adventitia is the outermost layer of the blood vessels, shown like this in the artery or in the vein. These are longitudinally arranged collagen 1 fibers. There are few elastic fibers. The tunica adventitia is very prominent in the larger veins. The tunica adventitia may contain a vasa vasorum and nerves in large blood vessels, be they arteries or veins, and the tunica adventitia may contain lymphatics. This just shows you how smooth muscle cells, here vascular smooth muscle cells, might interact with the extracellular matrix in the tunica media. So you can see the smooth muscle cells interacting with elastic fibers and collagen fibers. And there are various other microfibrils that help to bind these cells to the major extracellular matrix components. And remember, the smooth muscle cells are synthesizing and secreting most of the extracellular matrix components in the tunica media. This just shows schematically how tissues are arranged in large blood vessels. So the tunica intima contains the endothelium, and note that the endothelium are going to be arranged parallel to the way blood flows. The tunica media with the smooth muscle cells that are arranged perpendicular to how the endothelial cells are arranged, and then the connective tissue, the adventitia. And the diagram is just showing blood vessels, the so-called vasa vasorum, and nerves that are going to innervate the blood vessels. Now, the vasa vasorum are important because in large blood vessels, you're not going to get enough diffusion of nutrients from the blood into the deeper layers in the tunica media and into the tunica adventitia. So you actually have to have a blood supply that supplies the walls of these very large blood vessels. This just shows what a normal artery might look like, and just shows you how these arteries could potentially get deformed if there are mutations in extracellular matrix proteins. And a lot of mutations in extracellular matrix proteins can lead to very significant blood vessel pathology. So, for example, you might have mutations in fibrillin genes, in different collagen genes, or in elastin genes. And I'm going to leave this for you to consider later in your training in pathology. I just want you to be aware that mutations in extracellular matrix proteins can lead to significant blood vessel pathology. The vascular endothelium is a simple squamous epithelium. As we said, it's aligned, so the long axis of the epithelial cells arranged in the direction of blood flow. The endothelial cells express surface adhesion molecules and receptors. They give structural and functional integrity to the vascular wall. The endothelium serves as a selective permeability barrier by simple diffusion of material across the epithelial cells into or out of the blood. Also is involved in receptor-mediated endocytosis. So, for example, LDL internalization from the blood would be receptor-mediated endocytosis. There are transcellular and paracellular transport mechanisms. Also importantly, the endothelium serves as a non-thrombogenic barrier, and this barrier can break down in blood vessel pathology, and so you can get blood clots forming in the vessels. The endothelium can modulate blood flow through the vessels because the endothelial cells can secrete vasoconstrictors and or vasodilators. So some vasoconstrictors might be endothelins, angiotensin-converting enzyme, maybe prostaglandins, thromboxanes. Vasodilators might be prostacyclins or nitrous oxide, for example. The endothelial cells can also regulate and modulate immune responses. Endothelial cells can secrete a variety of growth factors, so different colony-stimulating factors, maybe fibroblast growth factor, platelet-derived growth factor. The endothelial cells can also secrete growth inhibitors, notably heparin and transforming growth factor beta. As you'll learn in physiology, the endothelial cells are very important as part of the renin-angiotensin system to regulate blood pressure because they convert angiotensin 1 to angiotensin 2. The endothelial cells can modify LDLs and VLDLs, and oxidized products of LDLs can be endocytosed by macrophages, which can cross the endothelial lining. Those macrophages, as they become foam cells, will lead to very significant blood vessel pathology. We'll talk about that a little bit later in this podcast. And the endothelial cells can contribute to smooth muscle contraction in the tunica media when they release some of these vasoconstrictors and vasodilators, especially under situations of metabolic stress. This diagram just shows the endothelial cells arranged parallel to how blood would flow, and here you can see that in the scanning electron micrograph. So blood would be flowing in this direction, coming in and out of the screen. There are three basic types of arteries that we want to consider. There are elastic arteries, so-called conducting arteries. There are muscular arteries, the so-called distributing arteries, and there are the little arteries or arterioles. The elastic arteries are often located close to the heart. They're under high pressure. So, for example, the aorta and pulmonary arteries. The muscular arteries or distributing arteries are downstream from the elastic arteries. These are the anatomically named arteries that you've already studied in gross anatomy. So, for example, the hepatic artery, the renal artery, the mesenteric artery. And then arterioles are located within organs or tissues, and these don't necessarily have a name associated with them. So what we're going to do first is talk about elastic or the conducting arteries. The diagram here on the left just shows an elastic artery with a histological view. So you can see the tunica intima arranged like this, the tunica media, and the tunica adventitia. Now, the tunica media is fairly substantial, and it has an internal elastic lamina associated with it. Oftentimes you'll hear people talk about the internal elastic membrane and the external elastic membrane. Those are synonymous with the internal elastic lamina and external elastic lamina. I happen to use the term internal and external elastic lamina, but if you see internal or external elastic membrane, it's saying the same thing. What's of significance here? There are these rows of smooth muscles that are in the tunica media, and interwoven between the smooth muscle layers are prominent elastic layers. This histological view is stained with a specialized stain for the elastic fibers, so you can clearly see the crinkly or squiggly elastic fibers that are all the way through the media of this large vessel. In the tunica adventitia, there'll be perhaps some macrophages, there'll be some blood vessels, you'll see some fibroblasts. You may even see some myelinated nerve fibers in the tunica adventitia. Here's a profile histologically of a portion of the aorta, obviously a very large elastic artery. You can see the tunica intima, the tunica media, very substantial in an artery like the aorta. You can see the internal elastic lamina staining here, the external elastic lamina here, maybe not as prominent, but you can see the prominent layers of elastic fibers that are throughout this media. The smooth muscle cells are lined up in discrete rows, held in those rows by these elastic fibers. There may be 70, 80 or more layers of smooth muscle in these large elastic arteries. And then here's a portion of the tunica adventitia, and here's a profile of a blood vessel in the tunica adventitia. Just a higher power view of the aorta. You can see here this portion of the tunica intima. You can see the endothelial cells. The tunica intima is a little bit exaggerated in the large blood vessels like the aorta, so you can see some fibroblasts in the tunica intima. Here's the internal elastic lamina staining, and here are nuclei of smooth muscle cells. Here are some elastic fibers that would be prominent if you were going further and further into the tunica media of this vessel. Here's the pulmonary artery with a trichrome stain slide. Pulmonary artery is also an elastic artery. We have a profile of the tunica media. Note the elastic fibers or elastic laminae that you can see. You can see nuclei of smooth muscle cells, tunica adventitia, and some profiles of vasa vasorum. Perhaps right here you're seeing the external elastic lamina staining. Here's the pulmonary artery with a typical H&E stain. So you can see the tunica intima like so. You can see the endothelial cells and perhaps some fibroblasts in the tunica intima. Note the smooth muscle cells in the tunica media. And even with this H&E stain, you can see the wavy elastic laminae that stain in the tunica media. I hope you appreciate that in arteries, the tunica media is the most prominent component or prominent layer of the arteries. This is just a scanning electron micrograph of what the elastic lamina would look like. All the tissue has been dissolved away and you're just seeing the elastic fibers. And a little bit of the histophysiology of elastic arteries. We'll talk about this obviously in physiology, but if you think about the blood pressure differences between systole and diastole, well, you have these elastic arteries that can expand and contract during systole and diastole, and that tends to maintain the blood pressure coming out of the ventricle at the early part of the systemic circulation. Let's talk now about the muscular or distributing arteries. Here, again, a diagrammatic view, the tunica intima, the tunica media, and tunica adventitia. And here you can see the histological view. You can see the tunica media still fairly prominent, but maybe not as prominent as in the larger elastic arteries, and the tunica adventitia. You just barely see on the histological profile endothelial cells. There's an internal elastic lamina and an external elastic lamina. Those are very prominent on the muscular arteries. It's kind of a matter of semantics if you want to consider the internal elastic lamina as part of the tunica media or part of the tunica intima, and if you want to consider the external elastic lamina as part of the tunica media or the tunica adventitia. It's not really that significant how you look at these as long as you realize that the internal and external elastic laminae serve as the boundaries for the tunica media. Here you can see diagrammatically in the tunica adventitia some blood vessels, fibroblasts, maybe some unmyelinated nerves. A nice histological view of a muscular artery. Look at the very prominent internal elastic lamina. You can almost always visualize the internal elastic lamina, and then the concentrically arranged layers of smooth muscle cells in the tunica media, and then adventitia like this and like this. Just a higher power view in the muscular artery, so you can see the internal elastic lamina like this. You can see some nuclei of the endothelial cells, and then you can see this portion of the tunica media. If you think about the histophysiology of muscular arteries, they have a smaller lumen, so there's an increased resistance. Blood pressure is starting to get decreased somewhat as you go downstream through the muscular arteries. And then finally, the little arteries, or the arterioles. Here is an electron micrograph showing an arteriole. Here you can see the histological images. Here we've got a vein and maybe a large and a small arteriole. Here happens to be a nerve fiber. These are shown in cross section. Here's an arteriole that's shown in longitudinal section, so you're only seeing perhaps one layer of smooth muscle cells around the wall of this arteriole. Here you can see the endothelial cells. The electron micrograph shows this nicely. Here are the endothelial cells like this around the lumen of the arteriole. Here would be some smooth muscle cells, the so-called tunica media in the arteriole. You can have what are called large and small arterioles. In a large arteriole, you can still see the prominent internal elastic lamina. For the point of view of an operational definition for our course, we can generally say that large arterioles might have 5 layers, at most 5 layers of smooth muscle in the media. The small arterioles may only have 1 or 2 layers of smooth muscle in the tunica media. Here you can see on the small arterial and endothelial cell and perhaps 2 layers of smooth muscle cells. Here I think I can see maybe 1, perhaps 2, perhaps 3 layers of smooth muscle cells on this little bit larger arteriole. And if you look at the histophysiology of the arterioles, lots of branching. So as you have lots of this dichotomous branching, the blood pressure is going to drop rapidly. And you would expect that as you get closer and closer to the end of the arterial system, close to the capillary beds, the blood pressure is going to be dropping. Now let's talk about arteries versus veins. The tunics of veins are not as distinct as those of arteries. The lumens also often appear larger and more irregular in shape for the bore size of the vessel. And as you might remember from anatomy, veins have valves associated with them. Here is just a high-power histological view of a valve. Basically, it's an infolding of the tunica intima of the vein. Here you can see the valve and the vein, infoldings basically of the tunica intima forming the valve. And I think you can appreciate the valves ensure that blood only goes in one direction. So blood flowing in this direction doesn't flow in the opposite direction. But you do know that sometimes, especially in the peripheral vascular system, those valves may not function as efficiently and you get a little bit of backflow. You'll get swollen veins, so-called varicose veins. There are 4 types of veins that can be described based on size. Venules are the smallest veins. They receive blood from capillaries that can be as small as 0.1 millimeter in diameter. There are small veins, medium veins, the so-called anatomically named veins, and then there are the very largest veins. The small veins or venules we can describe as either post-capillary venules or even muscular veins. There are small veins that are continuous with muscular veins. The medium veins are anatomically named veins. They're usually accompanied by arteries in histological sections, and you usually see an accompanying artery and a vein together on a slide, and oftentimes the adventitious of the artery and vein will blend together. The medium veins might have a diameter up to 10 millimeters, and then of course the very large veins like the superior or inferior vena cava or the portal vein. And this just shows an example of a medium-sized vein. So tunica intima, tunica media, tunica adventitia. Now what can you immediately say in relation to arteries and veins? In veins, the tunica adventitia is more prominent than either the tunica intima or the tunica media. You can note in the tunica adventitia, in these medium-sized veins, you may see occasional smooth muscle cells and even sometimes some bundles of smooth muscle cells. There'll be maybe profiles of arterioles and venules in these medium-sized veins. You may also see unmyelinated nerve fibers in the medium-sized veins. Here in the histological view, you can see the tunica intima like this and the tunica media like this. So in these medium-sized veins, neither the tunica intima nor the tunica media are that prominent, but the tunica adventitia is very prominent. The subclavian vein, portal vein, and vena cava, the inferior and superior vena cava, are the largest veins, and they have an interesting histology related to the tunica adventitia. There are bundles of smooth muscle in the tunica adventitia of these large veins. Here you can see that on the histological section like this. This is actually tunica adventitia from here all the way down like this, and these bundles of smooth muscles run longitudinally through the vein, so they're actually running parallel to the way the blood flows in the vein. Here's a little bit of the tunica media and just the very scant tunica intima in these large veins. The image on the left is a histological view of the portal vein. You can see smooth muscle bundles that are evident in the tunica adventitia of this large vein. Here's the tunica media, like this, with the smooth muscle arranged in a circular manner around the lumen, and the tunica intima with the endothelial cells. Here's an unusual vein. The great saphenous vein is very unusual in that it has smooth muscle bundles in the tunica intima. This is, I think, the only case that I know of where there's smooth muscle bundles in the tunica intima of a vein. And this is interesting because, of course, you know that a lot of times in coronary artery bypass grafts, they'll take pieces of the great saphenous vein. So this is a very highly muscular vein, and that may make some sense surgically why you'd want to put it in a high-pressure system like for coronary artery bypass graft. One does have innervation of some of these blood vessels, and the electron micrograph actually shows that. Some axonal ends in the tunica adventitia of a blood vessel. Let me take the last few minutes of this podcast and talk about a very significant clinical condition, artherosclerosis. This is the most common blood vessel pathology, and some significant results of artherosclerosis could be ischemic heart disease, stroke, and gangrene. Lesions will develop in the tunica intima of elastic arteries in arterial sclerosis. There'll be endothelial cell injury, which will lead to dysfunction. That will allow the endothelium to have increased permeability to LDL cholesterol, and that will also allow increased adherence of white blood cells to the endothelium. Remember that white blood cells might diaphodese into the bloodstream itself. There'll be an increased production of reactive oxygen species, which will oxidize the LDL. Monocytes will enter the tunica intima and will differentiate into macrophages, and there in the tunica intima they'll endocytose the oxidized LDL and will transform into foam cells. Then T cells and foam cells will form a fatty streak or lesion in the tunica intima, and that will eventually lead to plaque formation. As you know, risk factors for artherosclerosis might be hyperlipidemia with high LDL levels, hyperglycemia, especially in diabetes, hypertension, and smoking. Artherosclerosis is a complex disease. The lesions take a long time to progress. They may start to be significant by the 5th or 6th decade of life, but they can occur much earlier in life, especially if one has genetic predispositions to artherosclerosis. This diagram just shows some of the cellular interactions in plaque formation. This is important to get a basic understanding of it because you're going to come back to this over and over again in pathology, and you'll see it for almost all of your time in clinical practice. So here we're in the lumen of one of these large blood vessels. There'll be increased permeability of LDL on the endothelial cells. That will allow LDL to get into the tunica intima, where it's going to be oxidized by reactive oxygen species. Endothelial cells will express cell adhesion molecules that will initiate monocyte migration through the endothelium. The monocytes will differentiate into macrophages in the tunica intima. So here are the monocytes in the blood itself that crossing the endothelial wall, and the differentiating into macrophages in the tunica intima. They're going to phagocytize the oxidized LDL and transform themselves into these so-called foam cells. The endothelium will also secrete platelet-derived growth factor and other cytokines, which are going to stimulate migration of smooth muscle cells into the tunica intima. Remember, the smooth muscle cells are very active synthetically. They're going to produce extracellular matrix materials, proteoglycans, collagens. That's going to continue to increase the thickness of the tunica intima. And as you might imagine, you're going to get a bulge of this tunica intima into the luminal space. And as you bulge this tunica intima into the luminal space, you're going to narrow down the lumen. And so this is a low power micrograph of this atherosclerotic plaque in the tunica intima. This happens to be in the aorta. Here's a higher power histological view. You can see lots of extracellular matrix material in here. You can see these large foam cells. So this is tunica intima. It's very much expanded. Here's on the left an early and on the right a later stage formation of atherosclerotic plaques in the coronary arteries. Here would be the tunica media, here would be the tunica intima like this, and look, the fatty streak is increasing the area of the tunica intima here, and the lumen is going to become progressively narrower, again, as lipids and extracellular matrix materials accumulate in the tunica intima. In most instances, there'll be a cardiac event when there's 90% of the lumen is occluded by a blockage, and that's actually what's shown on this micrograph. This is a micrograph showing about 90% blockage in a coronary artery. This amount of blockage would indeed lead to a cardiac event.